Start the recording. And when someone asks you, what do you mean by considerations? Okay. And in the exam, if we are talking about any, like whosoever is listening this, any exam, or even practically, you are inside the, even you will become a consultant. Your resident can ask you, sir, we have a hypertensive patient. What will be the concerns, or what will be the considerations in that patient? So what will you tell? You will tell like this? No, this is not the answer. You have to be very pinpoint. What you have to be pinpoint. You understand my point? What now? Think objectively. What will be the problems in an hypertensive patient when you are giving anesthesia? What are the things? What are the challenges? What are the problems you will face? Now you try to answer this.
Sir, his blood pressure control.
Okay. What will be the
His
result of it?
Sir, if it is uncontrolled blood pressure, and then it may cause perioperative uh, risk or the
Yes.
patient
Okay.
harm.
Now it is now you understand what I'm trying you to speak out. Okay. Because business
Yes, sir.
and at the end of the day, practically you what you need is this thing. Okay. Not
Yes, sir.
hypothetical sentence that this way I will take history, I will do examination. No, this is not the answer. Like practically, can anyone refine the answer? Rabia, any Viva candidate? This question is actually, I'm at the moment I'm asking to people to for Viva, but this question is not for Viva only. Even if you are a resident, even if you become consultant, whatever stage you are, this question you need to answer. Okay. So if you have a hypertensive patient, just let me. Nobody wants to speak out. Umair.
Sir, whether
Yes.
his hypertension is controlled or not, and
Okay.
about the compliance, as well as
Okay.
I will ask about the macrovascular and microvascular complication associated with it, and organ failure and association with ischemia.
Okay. Like, yeah, like you said control. So if it is control or if it is not control, what will be the difference? Okay. If it is uncontrolled, there will be chances that patient can have hypertensive crisis. Okay. This will be one thing. This will be acutely, or as the word you use, macrovascular and microvascular. So what will be happening? That maybe this patient has problem with the retina, the problem with the kidneys. Okay. So actually retina is not much related to us unless we have a surgery in a posterior, prone position, hypotensive anesthesia. Okay. And so in that case, there will be more chances of aggravating the problem which patient has. So this is related to this thing. And you will have some, but in the table viva, you don't have time. You will just use this word microvascular, macrovascular, retinopathy, nephropathy, and macrovascular complications in the form of atherosclerosis. Okay. And so atherosclerosis will be either in the form of ischemic heart disease, or in the form of cerebral vascular disease, or in the form of peripheral vascular disease. Okay. Peripheral vascular disease will result in limb ischemia. Cerebral vascular disease will result in stroke or TIA, and ischemic heart disease will result in either arrhythmias, either ischemia, infarction, or failure. Okay. That's how you have to tell them. Now, now you understand? if someone asks you that you have a hypertensive patient, and so what are the concerns? So the answer should be that now we have a patient. So if either it is controlled or uncontrolled, this can lead to have a hypertensive crisis and microvascular or macrovascular complications in the form, because patient will have this thing, and now the other things will be related to the medications. Okay, so what will be the problems with reference to the medication? So you can tell either some electrolyte imbalance, actually hypotension, okay, uh, exaggerated, just a second. Electrolyte imbalance, exaggerated hypotension. What else? Hyperkalemia with AC inhibitors. Okay, reflex tachycardia. Okay, so like you can just
So
say that
rebound hypertension if drugs are missed.
yes, rebound hypertension also. And also actually very important thing which I miss here, hypertensive in the crisis, you can further say laryngoscopic stress response. Okay, laryngoscopic stress response. So it will be more than others. So if someone asks you, you have a hypertensive patient, this is the one answer they want to ask to you. In long case, you have to tell, I will ask the history since when it is there. This is not in table viva, my dear, or this is not practical answer. Practical answer is this one. Okay. So now whosoever asks you, you have a even if they don't ask, you have to tell. So either because of the disease process of hypertension or the medications, there will be, now I have given you a hint. Now you can make your own answer. Okay. And this will be practical also. Beta blocker, there may be bradycardia, there may be hyperkalemia. Alpha blocker, this hypotension and reflex orthostatic hypotension and reflex tachycardia. The AC inhibitors, dry cough, and hyperkalemia. Okay, so things like that you can make. Diuretics, electrolyte imbalance, hyperkalemia, and the hyperuricemia and hyperinsulinemia. Okay, so that's how you will make your answer. So similarly, this like you can have. Okay, so similarly, if a patient with diabetes mellitus, so what will you tell? Now try to answer. How will you make the answer?
So my concerns would be control of diabetes is comorbidities, micro and macrovascular complications related to diabetes, and then organ damage. His medication, whether he's on insulin or oral and hypoglycemic drugs.
Okay.
And sir,
Airway,
yes, sir, airway.
difficult airway, there are because of glycosylation, autonomic instability. So what can happen? Like this will be your concern that maybe now you
Yes, sir.
need, now what you need, you may need titrated doses. Okay. You need to have anticipated difficult airway. You can have arterial line. Okay, so this, like, if you know the problem, the control, because if the diabetes is not controlled, not only anesthetic problems, then also wound problems. Okay,
Wound healing issue with
wound
wound.
healing and all other infections.
Sir,
Okay,
gastroparesis.
gastroparesis leading to aspiration risk. Then these patients have chronic pain, autonomic this neuropathy related pain. Then what else? I was just thinking insulin related problems, oral hypoglycemics related problem. Just think that practically what will happen. Like what? Yes, another question. How will you choose the fluid? That will be also important. So there is a myth that you should not give ringer lactate, which is unfortunately wrong. You can give ringer lactate. There is no problem. Rather, if you are giving sodium chloride, it is hyperchloremic. So it is more causing more acidosis. So there is no problem in giving ringer lactate. You can control the blood sugar, okay, with the insulin. And with insulin, whenever you are giving insulin, you have to do frequent blood sugar levels and electrolytes, because there may be decrease in potassium when you are using insulin. Okay, so these are the things which you have to anticipate if you have a patient with in uncontrolled, for example, diabetes. Yeah, another thing, crisis, DKA, hyperosmolar, non ketotic
Non-ketotic coma.
coma, and the most dangerous is actually hypoglycemia. Okay, this will give you some time for, but this hypoglycemia can immediately cause problems. So if someone asks you what are the concerns, my dear friends, I request you, this is the answer. Not the way you people start, sir, I will do pre-op, intra-op, post-op, forget about it. Whosoever is telling you, I'm not saying they're wrong, but you are overdoing it. Even practically speaking, but just tell me one thing. If you ask the same question and I'm, sir, I will take history, sir, I will do examination, sir, I will have pre-operative, intraoperative, post-op. Just tell me, are you getting anything fruitful? Okay. So the concept of this pre-operative, intraoperative, post-operative, yes, will have that. Pre-operatively, if you want to see, you will have a detailed history, examination, and investigation to rule out, to see the extent of microvascular and macrovascular complication. Try to ratify these points, these words, because I can guarantee you that if you speak this word, the examiner will not fail you. I can guarantee you, even if you have a small mistakes, because some of the questions, they are not failing questions, they are just testing questions. For in that questions, they just try to test your nerves, because you have to be a consultant, and you have to face the surgeon, you have to face the patient, you have to face complications, anticipations. So if you are not mentally strong, maybe this is also part of your training to become mentally strong, that you should have everything prepared in your mind. Okay, so this is how you should make it. So I will suggest you the all common diseases and common problems. I suggest you to make a sentence for peds, make a sentence for elderly, make a sentence for smoker, make a sentence for pregnant, make a sentence for diabetes, make a sentence for hypertension, and I'm counting also high ischemic heart disease. Okay. So because I don't think so. Yes, make a sentence for obese. Okay, now just give an example. I'm giving you example. You have a patient whose BMI is 40. He is 35-year-old. Okay. So now if you want to see the, like, first of all, does all obese patients are considered to be a problematic? Like if you have a patient with BMI of 40, what things you need to see in that patient? You know, specific things you need to rule out. What are those things?
We need
So
to get a better assessment of the airway, get an assessment of maybe obstructive sleep apnea.
Okay. So for that, the word you used, just a second. Where is it? So what has happened?
So there will be altered anatomy.
Just a second. Actually, I don't know what has happened to my stylus. It's not working. Have you heard of stop bang?
Yes, sir.
Okay. What is stop bang?
Sir, it is an assessment tool for detecting a risk of obstructive sleep apnea.
So like
So for S, it's snoring. T for tiredness during the day. O for observed for obstructive sleep apnea. P for I think increased pressures. B for increased BMI. I think above 35. A for uh,
age.
A for age. Yes, A for age. N for neck circumference more than 40 centimeters, I think, and G for gender, which is male.
Okay, so stop bang. So you will say, for example, you have a score more than 3. Patient has a snoring, BMI is more, patient age is more. Okay, patient next, for example, you found. So then there are chances of OSA. So you will send the patient for sleep studies.
Yes, a
Okay,
polysomnography.
sleep studies, and then you will get AHI. AHI, and then you will make it as a mild, moderate, or severe OSA. Okay. So that is how you will, not every obese patient, sir, we have, so you will say, first of all, not all obese patients are same, but there are some problems which are same in all obese patients, like difficult handling,
Dif
difficult
difficult IV line.
handling, okay, IV line. Then what else?
Respiration.
Difficult airway.
Airway.
Difficult airway, not only, and actually, I tell you something, majority of the time, they don't have difficult intubation. They have difficult mask ventilation.
Yes.
Intubation sometimes is very easy, okay? But mask ventilation is really difficult. So
Yes,
for
sir.
for that thing,
We
how will you manage? So what remember one thing. In the exam, you need to know the problem. You need to know what the hell it is doing to your management and how to tackle it. So the answer to this specific point is ramp position. Rapid airway management position. So you bring a pillow in a way that not is actually it's a special pillow in which the proximal part is broader than the distal part. So actually you bring the external auditory meatus at the level of sternal angle. So you can just have a picture of rapid. Before I used to think that this is ramp position, like the virtual English word. But after many years, believe me, I came to know that this ramp is abbreviation of rapid airway management position. So this is a message to all of my friends that make a habit of doing ramp position in any patient. Even you, if you are not expecting a difficult intubation, if you want to save your back, if you want to make the intubation easy, if you want to decrease the trauma, if you make this ramp position in almost every patient, there is no problem at all. There are so many advantages of it, but there is no disadvantage. I don't think so there is any disadvantage, because there are three angles. There is one oral angle, then there is this pharyngeal angle, and there is one laryngeal angle. So you need to align these angles. So if you make position like this, and then you make sniffing dog position, so, or barking dog position, sniffing position, or barking dog position, and then these angles become straight. So it like we start the point from obese, and then we say we have difficult airway. So we are say there will be difficult mask ventilation. So we do the ramp position. Then again you say someone said about gastroparesis. Okay, so this is the problem. So how will you tackle it? You will use acid prophylaxis. You will do this ramp position, because this will make your intubation easy, and then you can have required pressure. Okay, and you can
Sir, for
have,
prophylaxis, we will use sodium citrate.
actually this is again when you remember one thing, I request all of you, trust your knowledge. When you will have the your like your way of speaking is correct, then whatever they are asking you can answer. So acid prophylaxis, there are three things. Number one, decreasing the pH, decreasing the volume, okay, and increasing the emptying. Okay, so actually these are two same things. So decrease in
pH
production.
तो increase करना, so we have to increase the pH, right?
I'm sorry, decrease. I'm saying decrease the acidity. You are right.
Right.
Increase in
Okay.
pH.
Sir, in
Yes.
every obese patient, will we do aspiration prophylaxis?
That's what I'm telling you, that there is no fixed rule. Okay, there is no fixed rule. You will see the situation, and then you will decide. Okay, there is no fixed rule for it. You will see the risk factors, you will see the NPO time, you will see, like for example, a renal failure patient, diabetic patient, a pregnant patient. Now you can find the patient related risk factors, surgery related risk factors, and disease related factors which can cause increase risk of either aspiration or increase risk of you the problems in which you are
Delayed
having
emptying.
delayed emptying. Okay, you are giving too much opioids, so this is a factor. You have an abdominal surgery, this is a risk factor. As I told you, CRF is a risk factor. Diabetes is a risk factor. Pregnant patient is a risk factor. Female, and you can combine this is with PONV. A number of things are common. Okay, a number of things are common, but there is a slightly difference between PONV and gastroparesis. So you will decrease the acid production. That's what I was trying to say, but I lost in the word. So decrease acid production with the ranitidine or omeprazole. Increase the pH with this sodium citrate, which I see. Which I tell you something. I'm doing anesthesia in 2004. I have neither seen it. So I don't know but in the exam you have to tell that we have to outweigh the risk versus benefit, because when you are giving this, actually you are increasing the volume. You also, because there is a concept of pH less than 2.5 and volume more than 25 ml or 0.25 ml per kg. Okay. So there are, knowledge, there is no limit to the knowledge. But again, maybe after a few years, you will have ultrasound. You will put it in the epigastrium and you will estimate the gastric volume. So who asked this question? That will we give acid prophylaxis in every patient? Who asked this question?
Yes, sir. Me, Dr. Meher.
Okay, so Umair, you understand now?
Yes, sir.
So this is how you have to understand. So if you are giving more volume, it will also increase the problem, but you will decrease the pH, so it has advantages. You will give metoclopramide or domperidone, it will increase the gastric emptying. And you will give this sodium citrate to increase the pH. You will give as I told you. So this is how you will anticipate. And then other problems in CVS, you have chances. Ultimately, the problems are related. CVS and respiratory system are correlated. How? Because if you have increased CO2, which will cause pulmonary hypertension. Okay. And pulmonary hypertension is leading to right heart failure. Okay. So this is cor pulmonale. Okay. So like you have to correlate. Then maybe like other problems, like as we discussed, difficult IV line. So if someone asks you what are the concerns, or they have given you a scenario, I have a 45-year-old male with BMI of 45, and patient is going for laparoscopic cholecystectomy plus lap sleeve gastrectomy. Okay, because this is a very common scenario. Practically we face it. There is a growing tendency to do these surgeries. So they will not ask you to tell the concerns of obesity. They are expecting that you are telling that 45-year-old male. So one concern will be related to gender. So a lot of problems which are more common in male gender. You should just think about smoking. You should think about ischemic heart disease. You should think about the problems related to age related and gender related. So that will be the selling point. Sorry, that will be the patient related. Then disease under consideration, maybe this patient has only no other medical disease, but only this obesity is itself is disease. So then you will have this stop bang, okay, and then you will see the problems in this patient in all systems like CNS, CVS, respiration, musculoskeletal, endocrine. Okay, but mind it, you don't need to tell because unfortunately you people are poisoned by your immediate seniors who pass the exam, and unfortunately they, I'm not saying they tell you wrong thing, but unfortunately they tell you like they overstate it. So for example, they don't tell you the most important thing, which is time. You have only 5 minutes for one table viva question, and this is true for all people. Any exam, you don't have infinite time. So you have to tell about the patient demographic, like as I'm telling you, 45-year-old male with smoking or addict or something or whatever is related to it. And then maybe BMI is only become also become its patient related. And then the specific disease, you can keep diabetes or hypertension or ischemic heart disease. So that will be the second bridge. And the third bridge will be the surgery. Okay, so with reference to surgery, urgency of surgery, risk in the surgery, bleeding in the surgery, position in the surgery, any critical step. I have actually discussed this topic so many times, but unfortunately, I don't know you people have seen it or not, but this thing should be in your mind. Like laparoscopic cholecystectomy, concerns are insertion of trocar. At that time, it can injure the viscera. It can injure the vessel. And then the second step is pneumoperitoneum. So pneumoperitoneum will have sudden effect. So if at that time the depth of anesthesia is not good, there will be chances of bradyarrhythmias or even decreased cardiac output or the other. You can just think about it, and then you can tell that there will be endobronchial intubation, airway pressures will increase. Okay. And the third step will be the absorption of CO2, and then further increase in end-tidal CO2 and effect related to CO2. So this is related to specific surgery risk, or you can say specific concerns. So also there are position related. So there will be some surgeries in lithotomy position. There will be some surgeries in prone position. There will be some surgeries in lateral position. There will be some surgeries in Trendelenburg, reverse Trendelenburg. So whatever surgery they tell you, try to filter in these steps. Okay, so then you will have a better control. So this is actually the topic which I wanted to discuss with you today, that what are the if they are asking you concern, what does it mean, considerations almost the same, implications almost the same. Okay, so try to, and then you will correlate to the anesthesia steps like preoperative. You don't need to tell. I'm saying, and you are wasting your time. If you are overstating something, you are wasting your time. Okay, so preoperative, and of course it is intraoperative, but you have to, if you say only intra, post-op, pre-op, but you are not telling the important things, it's useless. Like preoperative, maybe you need optimization. Okay, you need optimization, you need preparation of the operation theater in whatever way. Like how will you implicate it? You came to know that we have a pediatric patient. Immediately what you will do, you will inform the staff that we have a pediatric patient. So you have to need to warm the room, a specific circuit, if a specific equipment, specific needles, specific like medications, dilutions, whatever. So this is all called as preparation. Optimization, maybe anything to need to be optimized, or any this will be related to the disease as well. This is really related to anything. Optimization may be control of blood pressure, control of blood sugar, control of coagulopathy, control of any medications, control of any disease, control of bronchospasm, control of infection, whatever you can have, think. But think, any patient you will find something to optimize, or at least you can say this word: optimization, preparation, and then think about all the steps. Usually what are the steps? We give pre-medication, we prepare some monitoring, We prepare some acid prophylaxis. Okay. We prepare some things for airway. We prepare something like, for example, steroid replacement or opioid replacement. Think about it. Then, important thing, preemptive analgesia. Okay. So monitoring, word for monitoring will be, in addition to standard 1 and 2 monitoring, we will have a line in any case, or we have CBP line, or we have neuro monitoring, or we have urine output, or we need airway, specific airway pressures monitoring. You can have anything. Okay. Like if you have a pregnant patient for a surgery, in addition to standard 1 and standard 2, we have fetal monitoring. Understand my point or not?
Yes, we understand.
Okay. So like these are the steps. Then the party does not finish here. Analgesia plan. Analgesia
Excuse me,
plan,
sir.
you can. I'm sorry. Yes, please.
Sir, apologies. Can you quickly just enumerate the?
I'm sorry, by mistake it pressed my. Can you say unmute yourself, Rafe? I'm sorry, I just pressed the button.
No issue, sir.
Yes,
Sir,
please.
can you just kindly enumerate the 1 and 2 standard monitorings?
You know, this will be a waste of time. Standard 1 is, I'm sorry, Rafe. Standard 1 is
Yes.
presence of the patient, presence of the anesthetist. Okay.
Okay,
Presence
sir.
of the
Okay, sir.
trained anesthetist is standard 1. And standard 2, you think about the major system, and this is standard 2.
Okay, sir. Okay, sir. Thank you so much.
Okay. Like what will be the standard 2? Pulse oximeter, ECG,
Blood
Right, sir.
pressure, heart
and
rate.
tidal,
Electrocardiogram, and
and
tidal.
NIBP.
Okay, sir.
Okay.
Thank you so much.
And temperature. Temperature is also in standard 2. If I'm not wrong, just correct me. Okay. So other monitorings are all others. So please, in your answer, all the time, there should be that in addition to standard 1, standard 2 monitoring, we will have this. Think about from maybe ICP monitoring, you can see, you can have any monitoring. You think about it, neuro monitoring, evoke potentials, BIS monitoring, urine output monitoring, limb tourniquet pressure monitoring, abdominal pressure monitoring. You are having laparoscopic surgery, you will always say, we will always monitor laparoscopic pressure monitor. If you believe me, I tell you something, because we just start our answer like a damn fool, unfortunately. And I will admit myself that I failed in table vivas, not because I don't know, because believe me, there was no one to tell like this, like I am trying to tell you. That's why I message you every day without getting any response from you. But I'm so deep. I'm so deep that I'm knocking your doors again and again, because I know that this is very easy. This is very easy to have common things and have a grip on the common things, because if you know the common things, I can guarantee you that, like if you understand this thing, I guarantee you will never be in trouble. Okay. Like analgesia, preemptive analgesia before, like for example, you have to give paracetamol. Okay. You have to give NSAID. Another thing which is for preemptive analgesia is gabapentin. Okay. Then you can have local infiltration before incision. In many surgeries, you can do it, or you are giving some block. So this is also part of it. Then, just a second, please.
Opioid, sir.
Yes, I opioid, but in the way I will just tell you. Okay. So what will you do? Sorry. Okay. So IV opioids, then PCA. Okay. Then wound catheters. So this will be in your mind, that these are the things which I can use in the intraoperative and postoperative. Okay. Then in every patient, you should tell which fluid and how much fluid. If at least if there is something special, like you can use the word in any laparotomy patient, that in laparotomy patient there is a lot of fluid shift, so you need to give a lot of fluid. If you can say that if you have a patient with limited cardiac reserve, you will use a judicious fluid replacement. This is a word which will make your answer very fancy, very beautiful. Okay. So similarly, like the course of the patient recovery, how will you recover the patient, how will you reverse the patient. Okay, I missed some things. Inhalational agent, which inhalation agent will you use, which induction agent you will use, okay, which muscle relaxant you will use. So and you know all the things, just try to organize your answer. If something significant, like for example, with reference to diabetes mellitus, you should tell that, yeah, because sometimes there is glycosylation of joints, so you can have difficult like anticipated difficult intubation. But at the same time, if you have an uncontrolled diabetic patient, there will be more chances of autonomic neuropathy, and there will be sudden uh, decrease in fluctuations in blood pressure. So I would like to have arterial line, and I will try to use modified rapid sequence reduction rather than rapid sequence induction. Okay, so you can have modified rapid sequence reduction with rocuronium, especially if you have Sugammadex. If you don't have, then of course you can say that whatever is available, you can use it. You can use, like, saxamethonium is not contraindicated, but this is a reality that if you work in a setup where you have rocuronium and Sugammadex, like I don't remember in last 12 years since I came to Saudi Arabia when I use saxamethonium. I never use hexamethonium since 12 years, I think. Maybe one or two times, which I don't remember. I never use it because all the time, Alhamdulillah, I'm working in a hospitals where rocuronium and Sugammadex combination is there. So I never use it. Okay. Or in hospital, majority times we are using either cystatin or So I'm just telling you, you should have a plan for everything. Okay. So that was what I wanted you to know. And now, please, I request you that diseases, make a list of diseases, make a list of surgeries. By the way, I have made it. I will share it to you. Then complications. Okay. Then equipment. It will also come monitoring. So at least these 3 4 things you make, and you make a combinations. Patient with myasthenia gravis for lap chole. Okay. So what complication you will have? You can have delayed recovery. Okay, you can have altered muscle relaxant response, you can have post-op ventilation, ICU, so things like that. So make a combination. I will just show you, and then I will finish my discussion. I will just show you. Just a second. Okay, so that's what I was telling you. So whenever you are doing it, you make a risk factors for everything. Also, yes, blood transfusion need. Then in that case, you can have blood conservative strategies, tourniquet, limb elevation, hypotensive anesthesia, use of cell saver, use of tranexamic acid. There are so many techniques to discuss about it. So that's what I was telling you. Postoperative course, whether you are sending the patient to ICU. So please, I request you, just have a print out of this paper and make a modification in by your own. And whenever you are reading, instead of bloody cramming the words of the book, try to correlate every disease in that. Okay, what is the main category? What is the pathology? What is the mechanism of problems? How to diagnose the disease? How to evaluate the severity of the disease? Which systems are involved? And then try to make your system. How, like, and any patient you need to intubate. So any disease, it has problem with the either the use of induction agents or muscle relaxant, or there is any involvement of airway. This will be your concern. Okay, if you want to give any block, if you want to give spinal or epidural or peripheral nerve block, this will be area of your interest. So you will be thinking You want to give a spinal, is there any problem with the spinal? If you want to do the monitoring, is there any special monitoring you need? You want to give some fluid, is there any problem with the fluid? You have to take the IV lines. If you do, you have any problem with the IV lines? This is in every patient. Instead of reading the book, cramming the book, and again in the exam, you will realize what I'm telling you. That believe me, it's very easy if you practice. If you don't practice, you will always be haunting yourself and you are actually torturing yourself. So instead of wasting your time in reading, please try to correlate the points. Okay, so then it will become very easy, and then you will make the, as I was telling you, patient demographic related concerns, disease related concerns, surgery related concerns. Okay. And these points will be related to surgery. So surgical urgency, surgical risk, bleeding risk, position, duration, incision required, level of anesthesia required, possible anesthesia options, possible analgesia options, potential concerns and complications, specific age group prone for that surgery. Okay. Like for example, TURP will never be happening in a female or never be happening in a young patient. Usually 99% cases, it will be an old patient. So this is, I'm giving you example. So similarly, fractures, usually young patient have sports injury or trauma, but old age patients have osteoarthritic problems, joint replacements, or in pediatric patients, you have corrective surgeries, or you, again, trauma can occur in any patient, but there are certain surgeries which are related to certain things. And if you need any special equipment, location, staff, medication, logistics, like syringes is a problem, temperature is a problem, equipment is a problem, handling the patient is a problem. So please try to think every disease, every surgery in this way. Okay. So this is my message. And these things are available for all of you. This is the list of surgery. Please don't waste your, again, I am telling you again and again, don't waste your time in reading aimlessly. Aimless reading is useless. Like you should have answer for every disease. What is that disease? Like instead of reading too many things, like if someone ask you, I'm just taking few more minutes, Rafe or any who wants to answer this question, please don't be afraid. Rafe, just answer this question. Who's
Sir,
listening?
apologies, can you repeat?
I'm answering, asking a question. If I will ask you what is myasthenia gravis, how will you answer?
Okay, sir, we can start that myasthenia gravis is an autoimmune disease.
Yes.
The main pathology is that the acetylcholine receptors in the postsynaptic junction are targeted.
Okay.
Uh, because of their destruction, this leads to fatigue and lethargy, and it can lead to bulbar symptoms, ocular symptoms, and
One
and
important thing,
respiratory symptoms and
respiratory.
respiratory symptoms.
Okay. So like this is the answer you can have, that you can even squeeze this answer. What you used a word in our language, kam kharch bala nashi. You have to be concise. Darya ko kuze mein lana. You have to put like what you say, elephant into a small hole. Okay. So just try to be compact in your words. So you will say it's an autoimmune disease having this autoimmune destruction of postsynaptic acetylcholine receptor, resulting in muscle weakness, which is more evident in respiratory muscles, ocular muscles, and bulbar muscles. And that is more important for us, bulbar, because it will lead to aspiration of this respiratory muscles, because it will have post-operative respiratory problems. And there is altered response to the common frequently used anesthesia medications like muscle relaxants.
Not
And
yes, no.
yes, and there are chances of coexisting autoimmune diseases. The patient may be on immunosuppressants, which has widespread multisystemic effects. This patient might be on steroids, which can have serious implications on anesthesia management with reference to increase in blood sugar, steroid replacement needed. So you can even squeeze it, the answer, and you can finish it. Try to practice this answer for every disease. What is
Sir,
anemia? What is
another
Hmm.
point can also be maybe use of anticholinergics. So cholinergic crisis can also be a possibility.
Like, I tell you something in the exam. the thing is that you have very limited time, okay? And the examiner, whatever he wants you to speak out, he will take you there. So don't worry about it.
Okay, sir.
But if your
Okay, sir.
starting answer is correct, so my request, make a list of the diseases. By the way, I had made this list of these topics. You will find majority of diseases over here, okay? So you can have a list of the diseases and then try to make the answer for all diseases like this, okay? Like either it is a neurological problem, muscular problem, hematological problem. You should have answer for hemophilia, anemia, GB syndrome, myasthenia gravis, rheumatoid arthritis, tuberculosis, hypertension, diabetes mellitus. Like you can make your own list, okay? And complications. Every surgery will have some complication, so you should be knowing complicated. I have made, actually this is a crazy list because I put everything. But if you just divide it in the groups and any specific surgery, maybe you think that you don't know, I'm welcome to tell you. Okay. Otherwise, this is just a list. Don't be afraid. Oh, sir, we have to prepare 172 surgeries. No, it's not like that. It is just that you just should be prepared for it. If they ask you any surgery, you know about it. Like I remember, I was so ignorant that I'm just trying to tell you that if a person like me can speak out in front of you and you people are listening across the globe, this is I can tell you that when I appeared in the oral exam the first time, they asked me ERCP and I was so stupid and I was so ignorant, I couldn't even describe the abbreviation because I had never think about it that this question will be, because in my bloody Morgan it was not written. Endoscopic retrograde cholangiopancreatography, you find where it is written. How will you give anesthesia for endoscopic retrograde cholangiopancreatography? Where it is written to have a monitored anesthesia care, where it is written to have what is opioid sparing anesthesia, what is low flow anesthesia. So actually the problem is that unfortunately we don't think out of box. We just try to be very, very traditional. We just try to be having a tunnel vision. So please come out of it. Okay. And you will find majority cases, a lot of concerns are the same. But I will request you to at least have a look at it, because the surgery, whatever they are asking you, will not out of this list. I can guarantee you. This thing I can guarantee you. Because when I made this list, I saw, I think a lot. If some surgery is not written here, please do let me know. Okay. So thanks a lot for listening. This is a document for preoperative testing. I had 4 or 5 sessions, last 4 or 5 sessions with reference to preoperative assessment and interpretation of investigations and problem troubleshooting in the OR. So same is the problems which can be asked in the oral exam and in the talks. So from inshallah next discussions, I will try to have individual disease, but I will request you to have a detailed look on this paper. This is for anesthesia planning, and actually I have tried to, whatever you need to know is with reference to actually long case, also with reference to table viva. You can just think that what will problems will be there in it. Of course, in the table viva nobody will ask these things, so I have just made a default paper which you can use for anything. And anesthesia the goals, so I had made it like my best friends. So if you don't know anything, the target of a good anesthesia is to have normoxia, normocarbia, normotension, normovolemia, avoid sympathetic stimulation and stress response, maintain myocardial oxygen demand supply ratio, and also I should write it here, the vital organs blood supply, including liver, kidney, brain. Okay. Maintain sinus rhythm, maintain SVR, maintain preload and afterload, maintain right and left sided filling pressures. So, and actually, if you can utilize, if you have this thing in your mind, they are asking what will be your goals, what will you do, what is your target, and you don't know, don't remember. Believe me, if you will use some of these things, this is your good anesthesia. You don't want to have hypoxia. You don't want hyper or hypocarbia. You don't want hypovolemia. You don't want hypervolemia. You don't want sympathetic stress response. You don't want oxygen to the going to the brain or oxygen going to the heart decrease. You want to maintain the sinus rhythm. You want to maintain the SVR. You don't want to have any arrhythmias. So this is what is anesthesia. Okay. I hope you understand. thank you very much, because I have to thank you, because unfortunately, you people don't have the time to listen to me, and I am just knocking your doors. This is the list for this has some exam tips. This is some list of long cases. Okay, this is someone has made it. Though I hate notes, but somebody gave it to me, so I just put it in the Google Drive. This is again, you can make your own list. Don't try to ratify cram this list, but this is a way you can prepare yourself. The in the last previous 4 or 5 discussion which I had, I focused on the preoperative assessment, risk stratification, compiling the risk factors, and how to manage. And believe me, this is whole anesthesia. If you know this, I have discussed maybe this thing so many times, and you will find in the YouTube channel, in the playlist for this one. But please, I know that maybe you will be thinking, no sir, we are not discussing any disease. But if you know this pattern, there is more chance that you will not fail, because you are not duffer, you know a lot of things, you are studying since in medical school. So I will suggest you the discussions which I have done right now with you in the last few weeks. Actually, the last few discussions, the main chunk is here. This is what I wanted you to. You will come to know. This I have discussed: pediatric patient for anesthetist, pregnant patient for anesthetist, renal disease patient for anesthetist, liver disease patient for anesthetist, respiratory disease patient for anesthetist, cardiac patient for anesthetist. Okay, and position related concerns, optimization and anticipation before surgery. And believe me, because I have to tell you this thing, I have no interest. This is not a monetized channel. I don't want to earn anything. Even if I get something, I will give it to someone. I don't need it. But the thing is that if you understand this thing, this is for post-op, this is a concept of enhanced recovery after surgery. So because I am doing it for more than 2 years, or this in the form of this Zoom, and you will find the playlist. So for Viva, if you listen to it, these are a lot of scenarios being discussed here: gyneops, neuro, urology, liver, blood, pediatric anesthesia. So of course, and if you don't understand anything, you can just drop a message to me, and I'm there to help you out. And last thing, please remember this thing, that Viva, nobody is there to fail you, because there are so many things which have misconcept in your mind. Nobody is there to fail you. Nobody has any grudge. You have not stolen anyone's any sheep or horse or anything. Nobody is your enemy. They are like your fathers. They are like your elder brothers. They are like your mothers or your elder sisters. They are not. No, I can guarantee you. I failed 2 times and I passed in last attempt. But when I was failing, when I failed, I deserved to be failed. People forget, they don't have rational analysis, that what was the problem, why they will only tell, they asked me about ice pack test and they failed me. This question was asked to me, by the way, my senior gravis, what is ice pack test? I had no idea whatsoever what the bloody test is. You just put the ice on the eyes and there will be decrease and the increase in the, sorry, improvement of the ocular symptom. I did not fail because of this question, but I can guarantee you many people will come out and say, and they will have few questions like this, and they will say that I failed because of this question. But they asked me laser, and I was so confused that in laser surgery I confused it with the this one foreign body, and I was trying to do it without intubation, and I deserved to be failed. Okay, so remember this thing: nobody's there to fail you. So be confident, be confident, be confident. Try to speak out while looking into the eyes. If you are making your hands like this, you are looking like a stupid. Why they will pass you? They don't want jokers, they want consultants. They want someone who can handle the patient, a dying patient, someone's mother, someone's father, someone's brother. So okay, so and you can do it, so trust me. Okay, so thanks a lot, and I expect that you will spread this message to everyone, discuss the things, and you are welcome to ask any question anytime. Okay, I have invested a lot of time for you people. This is all for all of you, and my request: all you will pass the exam. Please don't stop this effort. When you pass the exam, don't forget your time. This time, I don't forget it. I'm talking to you. I'm feeling the pain which I had when I was stuck in the exam, and I am talking to you only because I don't want anyone else to be in that pain. of failure, because I failed one time, two times, and third time, last attempt. You cannot imagine the tension of last attempt. Okay, I have passed through it. So just help me out. Thank you very much. Bye bye. Inshallah, see you. And
Thank you so much, sir.
no problem.
Thank
You are
you, sir.
welcome. And in the links which I was showing it to you, if you have any problem, don't hesitate to drop a message to WhatsApp. I will answer. Okay. I contact and respond to anyone who contacts me, and I'm available all the time. This is my passion. Okay. Thank you very much. Bye bye.
Thank you.